This episode is sponsored by the International Critical Care Paramedic Group. So the ICCPG unites regions worldwide to enhance paramedicine through global knowledge sharing and improved communication amongst critical care paramedics. So following the success of their inaugural 2022 conference, which gathered over 600 paramedics from across the globe, the ICCPG is thrilled to announce their second conference on January 30th, 2025. So the first event, hosted by the UK College of Paramedics, featured speakers from the UK, Australia, New Zealand, Canada and South America, discussing the vital role and unique challenges of paramedics in their regions. So the 2025 conference aims to bring together paramedic professionals worldwide, exploring topics including case studies, followed by in-depth discussions on clinical, training, leadership or research aspects. So don't miss this chance to connect with peers, learn from international experts and advance global paramedicine. So mark it in your calendars for the 30th of January 2025 and stay tuned for more details about this online event. For more information, please head over to the show notes. This podcast is sponsored by the University of Hertfordshire. The University of Hertfordshire offers comprehensive undergraduate and postgraduate programs in paramedic science, preparing students for a successful career in the field. So their BSc Honours Paramedic Science programme features specialist teaching spaces and indeed advanced simulation facilities for hands-on learning. A dedicated paramedic teaching team comprising experienced professionals bring real-world insights into the classroom and help students gain practical experience. Students gain practical experience through placements in the London Ambulance Service and the East of England Ambulance Service as well. The university is strategically located, offering excellent access to London, the M25 and indeed the M1, enhancing placement opportunities and networking. The university also offers the MSc Paramedic Science, so pre-registration course, and this emphasises innovative teaching methods utilising online resources, virtual reality and state-of-the-art simulation kits. So research active teaching staff with a national and international profile provides students with the latest knowledge and practice guidelines. With over 25 years of heritage, the programme has a strong reputation and a successful track record. Graduates enjoy excellent career prospects supported by the university's robust network and industry connections. The University of Hertfordshire's Paramedic Science programme combines theoretical knowledge, practical experience and indeed research opportunities supported by cutting-edge technology and a strong professional network, making them an excellent choice for aspiring paramedics. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast with me, Lisa Burrell, and I'm joined today by Tim Nutbeam, who is an emergency medicine consultant and the medical lead for Devon Air Ambulance. He also has significant involvement in research and has been one of the lead authors for the exit trial, which we're going to talk about a bit here, amongst a few other things today in this podcast. So we're going to be exploring with Tim what we mean when we talk about spinal cord injury, how our care affects outcomes for patients, and where we're at in the evidence to support practice with all the work that Tim has been doing. So welcome to the podcast, Tim.
Oh, thank you for having me. I'm excited to be here.
Great. So we're going to take a little bit of a dive into spinal cord injury and what we assess in our patients, what we might find important in our patients, and what we can do for our patients. So shall we just start by what is spinal cord injury? What do we mean when we talk about this?
The spine consists of a structure of bones, and between or within that structure of bones is the spinal cord. And when that spinal cord becomes damaged, we often have neurological symptoms. And those can be long-term and have a very significant effect on people's lives. And I think one thing that we need to be really conscious about when we explore some of the harms and balances of the treatments that we deliver, that spinal cord injury is often for life and it has a massive impact on people's lives. And we need to make sure that we take that seriously. And when we're considering things like pain from collar, or pressure areas or pressure sores, or some of the harms we associate with over care of spinal injuries, that they're often short term, or they're often associated with cost or operational burden. But on the other side, spinal cord injury is for life. It has a massive effect on patients, and we need to treat that with absolute respect and delicacy. And I'm very lucky in that our research, we've worked with Aspire, which is a charity which is set up to help look after people with spinal cord injury. And we're really careful that we try and be as balanced with our comms as possible. Please don't take anything that we say here today as spinal injuries not important, or spinal cord injury we shouldn't care about because we're worried about other injuries.
Yeah, and that's one of the things that I really like about your work. Actually, there is this theme that goes all the way through your publications around patient-centered approach, and you've included patients and their experience, which is really, really important. And it's nice to see that actually that's the starting point of the conversation today. What has been your...
If there's one takeaway from the spinal cord immobilisation debate, or the extrication, I hope that debate's over, but extrication discussions, is that whatever we do needs to be absolutely patient-centred, and it needs to be absolutely patient-centred if the patient is uninjured, if they're only psychologically injured, if they've got a spinal cord injury, if they've got multiple other injuries. Whatever we do needs to be absolutely patient-centred and focused on giving them the very best outcome, whether that be a physical injury outcome or whether that be a psychological injury outcome.
Yeah, I couldn't agree more. I think that's really, really important, and shouldn't be overlooked actually, because we can dampen down something that can be quite rare and maybe undertreat people where we have a lower suspicion of the injury, because not always as obvious as we think it's going to be, certainly when we're trained about how spinal cord injury presents and the concept of a stable versus unstable spinal injury. Can you sort of expand around that a little bit for us?
Yeah, and I think so much of this debate comes from how historically we have risk assessed patients for spinal cord injury. And historically, we've considered from a pre-hospital perspective, here's a group of patients we need to immobilise, and here's a group of patients that we don't need to immobilise. And all that has been done on risk assessments, for example, the Canadian C-spine rule or Nexus, which have been based not on immobilisation criteria, but on imaging criteria. So when we talk about Nexus and when we talk about Canadian C-spine rules, these are large studies looking at many thousands of patients, and we're looking for the presence of a spinal injury, not a spinal cord injury. And as a result, when we take that evidence and apply it to a different environment, it just doesn't work. So that's why there should be three groups of patients in pre-hospital care. There should be those who will benefit from immobilisation, those who we've got concerns about their spine but won't benefit from immobilisation, and there's a third group who are probably Nexus negative, Canadian C-spine negative, clinical consult negative, who we don't need to worry about immobilisation for, and we don't need to worry about further imaging for. And actually that kind of binary cut-off, immobilise, not immobilise, I don't think's really got a place in modern evidence-based medicine.
Yeah, I think that's a really nice way to lay it out in those three categories. And actually that middle category of we think there's a suspicion of an injury, but it wouldn't be appropriate to immobilise is maybe quite an empowering category where people feel they can try to do the right thing for the patient without being restricted to certain methods of practice that they don't think are actually in that patient's best interest. So I think that categorisation could be really, really a useful concept for people for the future.
And I think what's important is spinal cord injury, and I know this might be on YouTube, so I can use my hands. Spinal injury is a big cohort of patients, and within that there is a much smaller cohort of patients who have a spinal cord injury. And just around that spinal cord injury are unstable spinal injuries, which might cause spinal cord injury if they're not looked after well. And we can talk about what well looks like. But spinal injuries as a whole, if you think about transverse process fractures, if you think about stable patterns of bony injury, they are never going to be unstable, and they're never going to lead to a spinal cord injury. And those are the ones who we perhaps need to image, but don't need to immobilise.
Yeah, and that's the subtle level of thinking that perhaps pre-hospitally we don't think about, because we don't always follow up what's on the scans and what the imaging can teach us to close the loop on some of those things. Sometimes we've used quite blunt tools to assess patients and not really got into that subtle detail. So that's really, really useful to hear. And one of the things I wanted to get into with you in this podcast is to just think as well about partial cord syndromes, because I think classically, paramedics certainly have been taught really well to recognise complete transection, loss of function below the point of the injury, but sometimes it's a bit more complex than that, isn't it? What's your experience around sort of partial cord syndromes, and how commonly do you come across that?
The more pre-hospital care I do, the less confidence I have in my own ability to accurately differentiate and diagnose patients. And there's been really interesting papers recently where they've got people who are the absolute masters of pre-hospital care, working in busy systems, consultant level, fantastic pre-hospital practitioners, and looked at their ability to identify life-threatening injury. And it's just not, we're really just not very good at it. So patients are so heterogeneous, age, physiology, comorbidity, polypharmacy, different situations, different levels of pain, different levels of stress, that actually us really accurately differentiating them and saying yes, no. We've been taught traditionally we can do that, but I think that's wrong. And I think it's all about having that having that suspicion, and then building a picture of your patient. And then importantly, from a pre-hospital care perspective, we don't need to diagnose them. We need to work out what offers this patient the very best patient-centered care. And sometimes that's going to be rapid care. Sometimes that's going to be really gentle care. And sometimes that's going to be immobilization, and sometimes it's not. So kind of, even though it's quite scary, I think it's really important that we accept that we're never going to get it right every single time, and we need to do what's really right for our patients. And stuff is hidden. We find stuff later down the line and go, oh my goodness, how did we miss that? Or was that masked by the abdominal pain, or whatever it might be? I think it's also important, people are built differently. The wires cross at different places. Spinal cord injury can be at a T10 on one side and a T8 on the other side. You can have a central cord syndrome where your arms don't work, but your legs do. And it's really, really complicated. And if you add variability to that, it's even more complicated. So I think a basic patient assessment: can you waggle your toes and move your legs? Can you waggle your fingers and is the pain associated with your cord, your spine? Is probably a reasonable place to start. And then you can get more into the detail later. But realizing that ambiguity and accepting it, I think, is part of good pre-hospital care.
Yeah, I think it's really powerful to hear you say that the longer you do this, the more difficult it actually becomes to have confidence. And I totally relate to that you see patients presenting in such different ways all the time. It really, really opens your mind, and that's really special, really powerful. And it's certainly opened my mind to start thinking about the different ways that these patients might present, and you try to get your head around the anatomy of why they're complaining of this symptom in this part, but a different symptom in a different part of their body. Could this all be linked to one lesion in their spinal cord? That can be quite hard and a sophisticated thing for people to put together, but just to have that open-minded view is really powerful. And I know that you teach this, and you have a simple model, am I right, that involves a monster munch?
Yes, yeah. So if you imagine a monster munch, it's got a hole in the middle and then 4 spiky bits around the outside. Effectively, a stable injury will involve the spiky bits around the outside, which is a metaphor for your spinous processes and your transverse processes. So when they snap off, the circle remain whole, and there isn't the opportunity for the cord to be damaged. Similarly, if you give your monster munch a little squish from the top down, once again, the cord is protected, and the ring of the monster munch remains whole. But once you start snapping that monster munch, then you can see how that then becomes unstable. It's in multiple parts, and that is when the center, that cord, which we're trying to keep protected and looked after, can become damaged. So that's a simple way of teaching spinal cord and spinal anatomy. But often at the roadside, we don't have that information, and we just need to go on the interpreting mechanisms of injury, what we know about our patient, our clinical consult, and our exam findings. But we don't need to identify the exact spinal level. We don't need to identify exactly what's going on, whether there's multiple injuries or a single injury along the cord. We need to make a simple assessment and say, does this patient benefit from immobilisation, or are they someone who I need to highlight and say they need further imaging, or are they someone that I'm happy that we handle normally and doesn't require further imaging of their cord or their spine?
That's great. And we talked a bit at the beginning about how the importance of this injury being permanent and disabling for people. But there is something about how these injuries evolve, isn't there, and progress and maybe improve or worsen. Can you just talk a little bit around your experience of that? Because I think those of us who only work pre-hospitally, we get a very small snapshot actually of the impact that our care has. And these are neurological injuries with secondary injury as part of the pathology. Just what's been your experience? What have you seen that's impactful for that?
Once again, there's some ambiguity and variability. On the whole, if you've got a devastating spinal cord injury, you're not going to do very well and have prolonged symptoms, and it's going to take a long time to recovery if there is any recovery. And if you've got a very minor spinal cord injury, the opposite is true. But we see huge crossovers between these groups. I had the privilege to be asked to speak at a Spinal Cord Association meeting a couple of years ago, and a third of the audience were patients. And some of them had the most incredible stories of recovery from really potentially devastating injuries that perhaps in hospital, in the emergency department, we'd have gone, oh, I can't see how they're ever going to have a quality of life. But they're living their best lives despite those injuries, and it's some incredible stories of recovery. I think it's important that we also realise the ambiguity in the evidence base. So generally, spinal cord injuries will present in a certain way, and then as a combination of kind of inflammation and other factors get worse, and then they stabilise, and then they enter recovery phase, normally after kind of days and weeks and months. But we do see some variation in there. And we also see quite significant differences in opinion around what makes a difference to that initial inflammation phase. So we're taught that oxygenation is really important. We're taught that maintaining flow is really important to the spinal cord. So that's maintaining a decent map. And we're taught that movement can cause inflammation, which can cause swelling, which can lead to a worse outcome. And if you actually kind of look into the evidence base for each of those, it's not really there. So much of it has been extrapolated from the brain injury data, if you like. So when we look after a brain injury, we know hypoxia is really bad, and we know hyperperfusion is really bad, and we know kind of banging it again is really bad. And we know from other injury patterns, if you've got a broken wrist, if you wiggle it around a lot, the inflammation will be worse. So we've kind of extrapolated this and then applied it to the spinal cord because we don't know very much about it. But once again, at this spinal cord injury conference I was at, there was a real debate between the neurosurgeons who were like, hey, you need to maintain the blood pressure with these patients, and the neuro rehab doctors who were like, no, actually, we should let the blood pressure do what it's like. That's all part of the adaptation cycle, and you shouldn't be giving pressors in the early phase of treatment. And these people know far more about spinal cord injury than I'll ever know. And the fact that they're having a stand-up debate is just shows you the ambiguity in the evidence. But like when there is a lack of evidence, we need to provide some sort of guidance, don't we? And the current guidance is avoid hypoxia, avoid major movements, and if you within your skill set, maintain that perfusion pressure, whether that be with blood products or pressors or a combination of the two. And ideally, the earlier the better. I think what's important is when we look at major trauma patients, they're often major trauma. So they've got a combination of injuries. Very few people have an isolated cord injury and no other injury at all. And often will have head injuries, chest injuries, severe abdominal injuries. And if you think about the physiological sequelae of those injuries, whether it be I've got a brain injury, I'm hypoventilating as a result, I'm therefore not oxygenating my spinal cord, or I've got a major abdominal injury, I'm bleeding around my spleen and my liver, and therefore I'm not perfusing my spinal cord. You can see that the combinations of these time-dependent injuries and the spinal cord injury kind of have not competing priorities, but they all need to be solved relatively quickly, which is why I believe from the work that we've done that entrapment motor vehicle collisions have poorer outcomes, even once you take into account physiology and injuries, because people are trapped in cars and because traditionally we got them out through an absolute movement minimization approach.
And that leads us beautifully into talking about the exit project, if you're happy to, and maybe just to take us through the journey of what you found through all the streams of work that's involved.
So the exit project evolved. One of my good friends is a chap called Rob Fenwick, who is involved with the resus room, and we've worked together on West Midlands care team, where I kind of found my feet in pre-hospital care in the mid-2000s, and we worked as I was a junior doctor, he was a junior nurse, and in emergency departments together in the Midlands. And it kind of evolved through this realizing that there was a disconnect between how we were looking after patients on scene, particularly in the extrication phase and the absolute movement minimization phase, and the injuries that we were seeing in hospital. And you can see that when you look at one of our papers looked at the rate of spinal cord injury in patients who were trapped, and it's about 0.7% of entrapments. So you think the other lot have got other major injuries. But anyway, what we realized was that it was this disconnect, and we wanted to know more. And effectively, we started doing some work in that area. And we did some work initially just working out how long extrication took. And West Midlands Fire and Rescue Service and a lot of other Midlands-based rescue services were really supportive of our work. They did live on-scene data collection for us. And effectively, we demonstrated that if you've got entrapment, you spend about 32 minutes stuck in your car. And we thought that was important. And we also found things like the factors which extend time in the car are when we, medics, paramedics, others get involved and do patient assessments and those sorts of things, definitely prolongs entrapment time. So we did that initial work and then realized that more needed to be done. And we took an evidence-based approach to that. So we used, literally, I hadn't looked at it since medical school, but it seemed relevant. So there's this lens of EBM, which involves what does the scientific evidence say? What do our patients want? And then what's going to be the experts' consensus on to take things forwards? And effectively, we worked with the National Fire Chiefs Council to apply for funding to support the research costs and the publication costs, and a charity called the Road Safety Trust, who are given money by effectively when you get caught speeding, when you go on one of those courses where you learn how to not, to drive safely, the profits from those courses go to this charity, and this charity distributes it to try and improve outcomes for people injured in motor vehicle collisions or prevent motor vehicle collisions in the first place. So we were lucky to get their funding and their support, and they've been absolutely amazing. And then effectively the exit project was born. There's 9 papers. They're all open access, but they all kind of gel together to either provide additional scientific evidence. So there's a paper looking at entrapment versus not entrapment and injury patterns. There's a paper looking at males and females and how they have different injury patterns, different entrapment rates. There's a paper looking at the effect of age on entrapment. There's 4, which seems excessive, biomechanical papers, with the key one demonstrating the difference between self-extrication and then 3 other kind of well-accepted extrication techniques. There's our patient and public experience. So we talked to people who had been trapped, and we talked to people who'd been trapped who had a spinal cord injury as well, and learned an awful lot about their experience and how it could be improved. And then that work all went into a Delphi consensus process using clinical and operational experts. And then we came out with some statements. And then we've been working effectively with people like the College of Paramedics and the National Fire Chiefs Council to translate that guidance into operational and clinical guidance. And that's where we are now.
Yeah, it's brilliant work. Fascinating actually to read through, and the differences that you found, between injury patterns in men and women, and the significance of the period of time that somebody's trapped for, or the significance of the fact that they're actually trapped, and how that relates to their risk of injury. It's answered so many knowledge gaps for us. So it's been such a foundational piece of work, and really given some substance to practice, I think. Maybe we're still in a place where we have to make pragmatic decisions, but at least we've got this data, haven't we, to help us balance and weigh up making pragmatic decisions for patients now, would you say?
Yeah, I hope so. And I think we've filled in the gaps the best we could with the resource available and where technology's at and data collection's at. I'm really keen. So bits of work we're working on now is the translation gap. So how do we spread the message? And obviously this is part of this, and give people permission to change their practice. And then we're also trying to look at how it will be effective elsewhere. So we were very lucky that I was asked to present our work to the UN Road Safety Fund, and we're in the early stages of a global health partnership, particularly working in Southern Africa, about how this and other elements of post-collision care translate into different healthcare systems. So it's really incredibly exciting. It's real, privileged to be part of this work.
Yeah, it's great. And what do you think are the knowledge gaps that still remain unanswered? What are the biggest questions that are still out there for you?
I think it's fascinating, kind of going back in time and looking at how we ended up where we are now. And as part of one of the foundational papers for the Exit project was a scoping review of the literature. We went really, really broad with that, looking at many non-medical sources of data. And when you look back, I can find no reason as to why we're doing what we do now. So my bias when I set out on the Exit project was spinal cord injury used to be a big thing, and then cars got better and safer, and now it's not. And effectively, kind of rescue practice hadn't caught up with that yet. But it's fascinating. You can look at post-mortem studies from the 1960s. You can look at databases in the States and in Australia and in Europe, tracking spinal cord injury over time. And spinal cord injury, of course, goes up because the number of users of motor vehicles has gone up massively. But if you look at spinal cord injury as a proportion of other injuries, it's remained like straight the whole time. Like it's about the same everywhere. And we've just done a piece of work which we're hoping to publish soon with looking at it internationally. And despite the huge ranges in types of vehicles available and in safety systems and in all these other bits and pieces, if you look at survivors, the rate of spinal cord injury internationally is about the same. So, does it vary? Yeah, but it varies between 0.5% and 1.2%. It's in that range rather than massive differences internationally. So it's fascinating to think how we got to where we are now, because the evidence base has never indicated that we should be where we are now. And if you talk to various people, they've got all sorts of interesting perspectives on that. And I wish I could get a detective involved and work out where I guess some people consider that we went wrong. And some people put it down to the seatbelt legislation in the 70s, that it was very because low-level neck injuries are so common. If you look at any advert, like it will have someone rubbing their neck afterwards. So low-level neck injuries are really common. That it was an easy sell to the public. So it's really easy to imagine someone with a spinal cord injury. I think everyone, if you say that, everyone imagines someone in a halo, or you imagine someone in a wheelchair, and it's probably quite easy to imagine. Whereas if you imagine someone with a chest injury, a really common injury associated with motor vehicle collision, it's quite I think the public messaging around that was perhaps considered more difficult. And I've certainly spoken to people who were involved with that legislation who feel that's where the focus on spinal cord injury came from. I've also spoken to psychologists who have said, oh, it's because neck injury, we've hung people for ages, as a form of capital punishment, and we've chopped their heads off. So neck injury is in the public zeitgeist, and chest injury and abdominal injury isn't. I've talked to people like there's a paper called Death in the Ditch, which I can give you for your show notes, but which was written by a medical professional whose relative got involved in a road traffic collision and did have a spinal cord injury, and that person was then involved with establishing ATLS, and ATLS hands were like hold onto the neck, so perhaps personal influence. And there's things like sorry, I'm rabbiting on, but I think it's absolutely fascinating. There was a chap who worked in Bristol as an emergency physician who had an OHP, and he taught on what at the time was the only like trauma course for fire and rescue people. And his first OHP, he said, the firefighters have killed more people than they've saved through the mishandling of the cervical spine. And the fascinating thing is this chap did his MD, so that's like a PhD, on post-collision care. And if you go back, and I've been a geek, and I've got his MD, I've had it photocopied from the library it was sent into, and the rate of spinal cord injury in his population is about the same as in our TARM population. So I've got no idea where all this came from. But the interesting thing is, my final conclusion is we need to have an open mind, and we need to accept that we might not get it right, and the exit project might not be right. So we need to revisit it every year, or every time there's a new way of collecting data, or every new data set, and say, hey, is this the very best we can do with our patients? And if it isn't, that's great. We change it and we move on. But being closed to that idea and saying this is absolutely the right way of doing it is the wrong way forward.
Yeah, and it's amazing to bring all of this together, actually, to start to streamline a way of thinking internationally, maybe interdisciplinary, multidisciplinary approaches, trying to bring together this ambiguity of the different mindsets and philosophies that people have brought in their practice. And then there's been maybe some clashes along the way in people being taught and trained and thinking differently. And so it's great to see this piece of work starting to streamline a way of approaching, it is important to bring that sort of sense of communication around what we're doing, I think, a little bit clearer. And I really liked the interim statement that you were involved in publishing in March of this year. The sort of conclusion of that, the theme throughout that is that people have been taught different guidance, and there is still different governing bodies and responsibilities that people have that they're working to. And I really like the concluding bit that says various guidance exists in this area, and as such, practitioners are likely to be supported to make different decisions. And that's always been a problem in the past, but that this should be accepted and handled with respect and kindness. And then I think that is extremely powerful, actually, because there's been some intimidation around practice before, and people trying to do the right thing because they're worried about getting in trouble with peers, really, or different disciplines. Or so it's starting to distill down maybe some of that anxiety around the management, as much as it as move forward decision making with more clarity. So I think that's brought some really important things.
I think we need to be aware of the limitations of the literature as well. So if you look at the exit project, it's about extrication from civilian motor vehicles. It's not about injuries on the rugby pitch. So you can't take the data that we've got around injuries from motor vehicle collisions, that mechanism of injury is completely different from a scrum collapsing, and say, hey, because this lot don't need immobilisation and can be asked to self-extricate, then this rugby player doesn't need immobilisation and can be asked to self-extricate. They're different groups with different injury patterns, and we need to be really cognizant of that. And when I'm talking about the exit project, I'm really clear that around those limitations. So it's about civilians injured in motor vehicle collisions in a higher income country, and we need to get the data, and we need to understand different groups before we can say, hey, we can apply it to all of these other groups as well.
Yeah, and while we're talking about those motor vehicle collisions, what's your view on the patient who's got high neurological signs identified in a motor vehicle and extricating that patient? We've talked a bit before about whether these patients should have rapid extrication for care or whether they should have more gentle and cautious extrication. What's your view around that?
So I think the exit project has got two kind of major challenges to our historical approach to extrication. So one of them is we should offer fair patient-centered care, and understanding the rates of different injuries helps us to do that. The second part of it was the biomechanical analysis, and effectively that demonstrated that that what we're doing just didn't work. So there's two aspects to this. So one is what's right and fair to the patient in front of me. How am I going to interpret their injuries and offer them the very best patient-centered care? And the second is roof-off extrication just doesn't work. It doesn't offer it doesn't work as sold. So we were sold, if you take your time, it will offer more or less movement, more movement minimization, and that's not the case. So if your patient can self-extricate, that will give them about half the spinal movement of someone who needs to come out from a roof-off type extrication, and all the other all the other extrication techniques performed about the same. So beat post rip, roof-off extrication, rapid X, they were all about the same. And we've also, there's work that we've published, but we've also done lots of work around the outside of it, using different movement capture techniques, using different vehicles, working with different crews. We've worked with kind of expert extrication teams. We've worked with people kind of develop their own type of extrication approach. And effectively, none of them are as good as self-extrication. And all of them are about the same. Of course, expert teams can do it quicker. Of course, expert teams can do it with a little bit less movement, but nothing like the movement associated with self-extrication. So if you're in a situation where all extrication techniques which aren't self-extrication perform in a similar way, you've got to differentiate between them in a different way. So biomechanically, they're similar. How are they different? And they're different in terms of time. And if we accept that we can't assess our patients thoroughly, and if we accept that there's ambiguity of our clinical findings, then time does become important. And time to intervention, whether it be a decent clinical assessment, whether it be protecting someone's airway, whether it be getting them to hospital, is all important, both from a physical outcome and from a psychological outcome as well. And so actually we should choose the quickest technique. So what we're saying now is choose the most rapid technique that you can apply to this patient. So hopefully that will help give people direction on the way forwards.
Yeah, that's really helpful. Thank you for that. And you are actually you're bringing some real clarity, I think, to a very, very difficult area with some very clear thinking around, but in a lovely balanced way. What do you think is the future? What updates might be on the horizon? Where do you think we might be going with all of this?
So what I really hope is, kind of as I've alluded to before, that we keep a really open mind, so that we keep an eye on the data. We see what happens as different extrication techniques or the exit project principles are adapted. We've already seen a number of roof-off extrications on home office data kind of crash, which is fantastic. That's probably the wrong word to use. They've gone down significantly. So we need to kind of keep we need to keep an eye on the evidence base, keep asking these questions, and work out how we can improve patient care for the best. I'm really interested in, one, how do we translate that effectively? So how do we make paramedics on the road and firefighters on the road feel empowered to make these patient-centered decisions and feel supported in making those patient-centered decisions? And also, I'm really interested in how this work translates into low and middle income countries. So, now, if you're aged between 5 and 30, the number one thing likely to kill you is a motor vehicle collision. So it's not major disease, it's not any of the other things that we've worried about over the years. It's road injury, and that's obviously a major global health disaster. And recently, in the last few years, we've had a decade of action from the UN and from the World Health Organization to target motor vehicle collisions. And the number of deaths and injuries associated with motor vehicle collision has gone up. So this is a major issue. And 93% of those deaths are occurring in low middle income countries. So for me, it's great that we're doing really good work in the UK, and it's great that it might make a difference to tens, hundreds, hopefully thousands of patients, both in terms of their injury burden, but also their psychological recovery. And that's fantastic. But I'm really also interested in how that work might help elsewhere and how we translate it effectively into those environments.
That's brilliant. Actually, that's so inspiring, because we get as far as seeing how things impact our little circle around us and our practice and our patients, and that is the responsibility we have to take some of this evidence out and make change in other communities. That's really inspiring. Thank you for sharing that with us, Tim. And as we just kind of bring this conversation around now, it's probably time to wrap it up. What are the sort of key messages or the bits that matter most in all of this to our patients? What would you say those are if we distilled that down?
Yeah, so I've always been a quantitative researcher. So I've been interested in data and randomized controlled trials and numbers and stats and p-values and OROC curves and other really sexy things like that. And as part of this work, the Exit Project, I was pushed into considering qualitative research and finding out about what our patients wanted. And I have to say, I was a complete cynic. I was just like, I'll do it because it's on the evidence-based circle. I don't really understand much about it, but we'll do it. And I'm so glad that we did it. And I learned so much. And I've really encouraged people who have that, to one, read the paper, and to consider it in their own ways when they're considering research. I thought our patients would be worried about pain or temperature or noise, and I was just like, you know what, we'll give them some earplugs and we'll give them some strong painkillers and all will be well. But the more time I spend as a pre-hospital clinician, it certainly fits my experience of talking to patients afterwards. And it came across strongly in the paper is the importance of being kind, using language that people understand, holding a hand. That's what people remember, and it's what's important to them. So remember that motor vehicle collisions are the second most common cause of trauma. We go to them all the time. Like, you've probably been to some this week, I've been to some last week. It's kind of bog standard for us. For that person, this is the worst day of their lives, and it's going to affect, even if they're uninjured, it's going to affect them significantly from a psychological perspective for ages. And I think it's really important to remember that. And it's really important to remember that these people really care that we're there and really care that we are holding their hand and that we're looking after them and we're telling them that they're going to be okay. And actually, the other stuff we do, actually, they don't care if they have ketamine or fentanyl. They don't care, which of these things that we worry about so much. They care that they had someone with them soon and they held their hand and told them what was going on. And that was, that I took that away from that, and I've certainly changed my practice as a result.
What a powerful message to leave us on, Tim. And I think that seems like the right place to leave this conversation, actually, because there's been so many really good takeaway messages to come through to us clinically, but to leave it on thinking about the human at the center of some of these terrible things is just brilliant. And your messages are genuinely so inspiring. The work that you've done, it's been great to talk to you today. It genuinely has. I've absolutely loved the conversation, and some of your tips, some of your insights, some of your wisdom that's come through, because this has been such a huge and long endeavor of work. And where it's taking you, the international perspective, I think, is a real inspiration to many of us. So just thank you so much for taking the time to share with us on the Pre-Hospital Care podcast, and we hope to talk to you again at some point soon.
Thank you very much. I guess my one last plea is I've got three things, I guess. One, always try your best to offer patient-centered care. That's why we're here. The second is to make sure that I express my thanks to the Road Safety Trust, who funded the research aspects and made sure that all those papers are free and open access, which I think was so important. And the third is, please keep an open mind. If the exit stuff isn't working, please let me know so that we can make it the very best that it can be. So reach out, give me that feedback, and I'd be really happy to hear it.
Great messages, and we will certainly include with all those links in our show notes. Thank you, Tim, and thank you for your time today.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.